There is an operational problem in our healthcare system that is embedded in the healthcare system, but if you could have the same operational problem in a manufacturing system or somewhere else. It's not so much about healthcare as it is about operations and getting the right healthcare at the right time to the right person in the right way without a lot of unnecessary cost and drama. And we're terrible at it. You go to the most expensive and inefficient industrialized country in the world, and we're 50% more inefficient than they are. So that's not something that America's ordinarily known for. We started off in the Rhode Island Quality Institute with trying to take some of the principles that airline pilots use to check things off and make sure they're done before you do, say, insert central lines in the intensive care unit. We wanted to reduce hospital-acquired infections, and we did in the intensive care unit to more or less statistically zero in Rhode Island, following what are known by people in the field as the Pronovost principles. Nothing to do with healthcare, all about checklists. If you go a little bit further, you'll see that pretty soon I surrendered my BlackBerry earlier, but your personal
I
data,
have my phone in my pocket.
your personal data machine is going to be able to help you negotiate and navigate through healthcare in a very big way very soon. And it's an emerging industry, it's a big industry, and the ability to process big data and to draw out of what we're developing in terms of our electronic health records and the payment computer records of the big insurance companies and Medicare, that's all going to come together in a very, very big way, and that's going to have a huge effect on healthcare.
Let me ask a dumb question, which is you say, think of the most inefficient market you can, and we're worse than that. You say it's not something that's typical to the United States.
No, we usually do pretty
well.
So
let me ask you this, why?
Because we have such an awkward, complicated healthcare system with so many different competing interests. A lot of times, the purpose of the exercise is to throw the mess from your foxhole into the next guy's foxhole, rather than to clean up the mess. And that's a lot of wasted effort of throwing the mess around the foxholes. Probably the best example of that is the fact that we can't seem to get together to get rid of these hospital-acquired infections. Mm-hmm. Another example, the Cranston Community Health Center in Cranston, Rhode Island, on Cranston Street. You go there, and when I was there on my last trip, I asked how many of your employees are delivering anything related to healthcare, and how many of your employees are fighting with the payment system over getting paid, and it was 50-50. And if you go to any, I can hear it out in the audience right now, you go to any doctor's office, and they have this huge infrastructure of folks who are designed to figure out how to fight against the huge infrastructure that the insurers have designed to prevent them having to pay you. That is all dead weight cost. It's absolutely no value in healthcare, not a nickel of value, and if it's 50% of the personnel cost of the Cranston Community Health Center, that's a pretty big piece of their budget.
You mentioned that split of 50% basically infrastructure costs, just getting the healthcare managed. Let's talk about before you get to the doctor. Yep. Preventative care, obviously a big topic. Can you talk about whether you've seen successes on the state, in Rhode Island or national level, about before people get there, given the inefficiencies? Obviously, we need to address the inefficiencies within that system that you've just talked about, and it's clearly a problem. But what about before that step?
Yeah, you're seeing it in a bunch of different areas. You're seeing it in public health arena, smoking cessation, smoking reduction. You're seeing it with chronic conditions. Better treatment of diabetes, better management of that condition so people aren't losing their eyesight, having to go in for amputations and things like that. It shows up in a lot of areas, and once again, because of our strangely carved up healthcare system, you end up with a weird predicament in which one person has to spend money to get that prevention method out there, and another person saves money from it being out there, but they're not the same person.
Right.
So this interest says, well, why am I spending money so that you can save money, you the insurer? And so you have to pull together, my favorite story on this comes from Dallas. Back to the information technology network, which is a very important way to pull people together. They have a health information exchange in Dallas. And it is connected not just to the hospitals, not just to the specialists and the MRI shops and the laboratories, it's connected to the Dallas County Jail. Because they have figured out that when people come out of jail, that's an incident that is going to impact the cost of the healthcare system, and they need to be preparing for it. And so you're also seeing this sort of general sense that you can't just build a wall around the healthcare system and say, okay, once you get in, here's how we're going to behave. You got to reach out to it. You got to reach out to the community centers, the community health centers. You got to reach out to in the case of Texas, they reach out to the jail. Who knew?
Talk about climate, and President Obama moving on this relatively aggressively. Talk about climate, not something we typically think about with, at least let me say, not something I typically think about as it relates to healthcare. Tell us why we should.
I think the Clean Air Act sets a pretty good model for this. If you look at the Clean Air Act, and it cost a certain amount in order to implement the changes that were made to clean up the air, then we've actually gone out and measured the benefit against that cost. And it turns out for every $1 in cleanup cost, there's going to be about $30 in benefit. And when you drill down into what the benefit is, it's very heavily in the healthcare sector. It's very heavily in prevented illness. It's very heavily in reduced hospital visits, say children being taken in with asthma, loss of work from the mom having to go in with the child with the asthma attack, all those things. So there's a very big public health vector. When it comes to climate change, you're going to see it in the northward move of tropical diseases and tropical pests that carry disease. You're going to see it in heat-related illnesses, heat strokes and things like that. There's a whole variety of ways. The most disgusting thing that I've seen in the course of my climate change work has been moose in New Hampshire, who now can have as many as 50,000 ticks crawling around on them. Ugh. And the ticks, of course, swell up as they feed. And you have young moose that die because they simply can't make enough blood to support their own bodies and support the tens of thousands of ticks that have climbed up on them. And that's because the snow cover has retreated. So the ticks have exploded because the snow was a real deterrent for a tick, I guess. So that's not our species, but it's an example of how climate change on a mammalian species can have a really very significant impact as pests and illnesses move around that we're not adapted to.
You were a architecture major at Yale.
Yeah.
I've read your bio, your resume. Did you ever think, maybe you did you ever think that buildings, how they're constructed, how they're built would be something that we'd be talking about in relation to healthcare?
When I was trying to be an architect, which was something I failed at, by the way, that was not really part of the program. It was much more design-y oriented. But just recently I visited a school in Rhode Island that is now effectively on a net basis off the grid. And it's very, very good, obviously, for that school department's utility bills. And what they're saying is that on the side, it's also amazingly good for the health of the kids in the school. That asthma goes down, that the kids are breathing cleaner air as a result of the LEED, super high energy efficiency of the school. So I think it's a very good vector into young people's health. And we may want to fight with each other about climate change and health issues and Obamacare and all that stuff, but at a very bare minimum, we ought to be looking out for our kids without too much nonsense.